Good evening to everyone and welcome to today's session. Roshan, Wasim, Albatross, Madhu, Richa, and many more who are all online. Welcome to this wonderful evening. and Yesterday we had been laboring to become a champion in the area of 200 questions of AIIMS. It will be a real eye-opening session, and it is the one which makes us more focused when we go for the exam. So there are a few questions which are left over, around 100 more questions we will try to discuss today. And from tomorrow we will start the physiology. Another 4 days we will finish the physiology. There is about 700 MCQs of question bank, topic wise organized, totally around 50 topics. Can the online students can punch whether the voice is loud and clear? So you're all ready with the game, doctor? Every 12 seconds a slide changes, and be very sure to take a lead in answering the questions. So let's make the great beginning. The time, it is your time, your show, and your participation and your active intervention. That is all what we are looking for. Shortly, I'll be vanishing from the screen. Keep punching your answers, doctor. Satapati Kirti, Athar, Mayank, Sundaram, Albatross, Satish, everyone. Keep punching your answers. Wildly guess what is the correct answer. When you are answering every day around 100 questions, extempore, that is a way to sharpen the saw. You make a guess, you shoot a stone, the stone may hit or may not hit, but during the discussion you will know where you have overshot it. That is how every day you should sharpen the saw and get ready with a cutting edge perfection by the time it is January and you all take NEET PG. Prasoon Vaidya, Akhila, Taiba Rahim, very nice to see you all, guys. Indian Observer is saying, sir, is the folder of the solved paper discussions available on the onlinembbs.com? I'll just check with my production team and ensure that there is a place where they put that. There is a folder called, there is a course called as 30,000 hot MCQs. Please speak with our helpline to get access to that. And in that you can get the exam wise discussions that we have done. Our WhatsApp group is becoming very popular day by day, and across 24x7 there are innumerable discussions, MCQs, student to student reviews. I'm very proud to see you all buzzing in action across the day on the WhatsApp group. Those who have not yet enrolled in the WhatsApp group, please click the link and join the WhatsApp group. Excellent, doctor. So you have now, you are now very sure as to what are the questions and how best you can extempore can be able to answer the questions, which is very important. Now let's make the great beginning of the AIIMS paper. Pharmacology questions, let us see. SGLT2 inhibitors. They are recently used in type 2 diabetes. What are the side effects of them? You should remember that ketoacidosis, Fournier's gangrene, and a urosepsis can all happen with the SGLT2 inhibitors. We had a great discussion about this in our regular class. All diabetic drugs and the classification, doctor. Diabetes drugs, insulins. Definitely examiner 100% guarantee topic hai. Without that there is no paper. What are SGLT2 inhibitors? Canagliflozin, dapagliflozin, empagliflozin, इनको कहते हैं SGLT2 inhibitors is what you need to remember. So you have the Bowman's capsule and proximal convoluted tubule. So proximal convoluted tubule is also called workhorse of the nephron because bicarbonate, sodium, all absorption occur in the proximal convoluted tubule, even glucose. So fundamentally what these SGLT2 inhibitors does is they act on the proximal renal tubule and prevent the reabsorption of the glucose and lead to development of glucosuria. Glucosuria is what you need to remember. Same time, they will also decrease the sodium reabsorption also in the proximal convoluted tubule. So once the glucose is lost into the urine, obviously that tempts the body to break down the fat, release the acetyl-CoA, and from that acetyl-CoA you get all the ketone bodies, right? So that stimulates lipolysis, free fatty acid production, increased beta oxidation, formation of the ketone bodies, and that lead to the development of the diabetic ketoacidosis, which is the adverse effect of the SGLT2 inhibitors. So for the tomorrow's exam, what are you going to remember? Canagliflozin, dapagliflozin, empagliflozin are the SGLT2 inhibitors is what you should remember. So what we are talking here is the sodium, potassium, calcium, magnesium, chloride, bicarbonate. All of them are fundamentally reabsorbed in the proximal convoluted tubule is what you should remember. And typically the glucose and sodium, SGLT2 is the one which will be co-transporting across for the reabsorption to occur back into the blood. If you happen to inhibit this SGLT2 inhibitor, obviously that lead to development of the glucosuria is what you should basically remember. So one more important point is, once the SGLT2 inhibitor is given, you are creating a situation of glycosuria. And the glycosuria leads to increased phosphate concentration in the blood serum. And that lead to sustained release of the parathormone and the increased fibroblast growth factor, and that increases the urinary phosphate and lowers the 125 hydroxy vitamin D, and that lead to development of an increased risk for the fractures of the bone is what you need to remember. So that is a important point that you need to know, that why these receptors, uh, inhibitors, SGLT2 inhibitors, enzyme inhibitors, lead to the development of a risk of fractures. So, Sethu Murugan rightly points, it is the best drug to prevent the micro and macrovascular complications. There are a lot of good things about it, but there are also certain bad things about it when it comes to it. Now, why phosphate increase? Mayank is asking a very good question. There is an increased phosphate concentration in the blood serum. See, the point is, what is the main way by which phosphate is captured? Glucose become glucose 6-phosphate, right? Glucose 6-phosphate. And if the glucose is available, it leads to development of glycolysis. Glycolysis will capture the phosphate in the form of ATP. So all that phosphate is no more utilized if the glucose is not available and it is lost into urine, and that lead to an increased phosphate concentration in the blood serum. That is what Mayank, I'm sure, could be able to understand. So Mayank is our predominant participant in the WhatsApp group with very active answers. Question डालते ही आंसर निकलता है, डॉक्टर मयांक से. I always love such people with a huge enthusiasm. All the winning of the game, doctor, is enthusiasm, energy, teamwork. Once we are in a same WhatsApp group, it's a teamwork. And today, a lot of you guys in the WhatsApp group had been putting up handwritten notes while reading in the reading room. So that is another very good way. Contribute and then get contributed. That is a way you become a winner in entrance exam today. YouTube, WhatsApp, they all have revolutionized the opportunity for a globally dissipated teams to work together. So thank you very much for all you guys for the wonderful participation. Propranolol is a drug of choice in the case of the ulcerated infantile hemangioma. So typically this is a ulcerated infantile hemangioma. So your whole plan is to bring down the pressure of the blood in that. So propranolol is considered to be a good way of treating. Now, which antimicrobial drug versus the drug of choice? Very good question. Almost doing the AIIMS question bank. Mahidar is saying, sir, can you please add me into the WhatsApp group? Shortly, I'll be pasting the WhatsApp group link. We started the first WhatsApp group, study group. 2 days back, it is full, 265 students. Then we opened 2 more WhatsApp groups now, and they're almost getting full. No problem, we can open any number of WhatsApp groups. Emails, WhatsApps are all free, right? So definitely I'll do that, Mahidar. I'll be adding you, I'll be posting the link. I just asked our office to paste that invitation link, and you can click on the link, tell your friends also to join, and also when you are in the group, keep writing a handwritten notes of some important points that you are able to remember and contribute that notes. You can even contribute a voice file of a revision. So that way it will help others. And in order to create that voice file, you yourself is indirectly doing a revision. So that is how the preparation should go on. Right, Doc? Now, what is the matchmaking over here? Praziquantel is tapeworm. Mebendazole is Ascaris lumbricoides. Nitazoxanide is the one which is used for the giardiasis. And DEC, of course, easiest question. Filariasis is what you should remember. So these are the nitazoxanide tablets, doctor. इसका दर्शन करो. Nitazoxanide is recently introduced to treat giardiasis. It is also effective against amoebiasis, trichomoniasis, cryptosporidium and ascaris is what you need to remember. It is a prodrug, and on absorption it becomes tizoxanide, which is an inhibitor of the P4 enzyme and affects the electron transport mechanism in the anaerobic organisms. That is the reason we basically use nitazoxanide is what you need to remember. Good to see Harish Reddy also joining online. Very good. Guys, we are, some of you may be from Hyderabad. I like to tell you that in Hyderabad we have an office in Nampally. And it's a very big office. Once upon a time, when face-to-face classes used to happen, I used to have around 200 students sitting in the class. Nowadays, it is all distributed team. I'm sitting in the home, in my study room, and able to live broadcast this session, right? So this Nampally, we are converting that into a reading room exclusively for the NEET PG and FMG preparation. Those who are in Hyderabad, please feel free to call us, and you can join that. It will be open from 9 a.m. to 9 p.m. all the days, all the 7 days. You can be able to comfortably, around 20 people it can be able to take, you can be able to join the reading room, right? So what you basically require, doctor, in the modern times is a good reading room, a set of friends, real-time friends with whom you can have a real chai, and evening you have a virtual friends जिसके साथ आप चाय पे चर्चा कर सकते, and a good WhatsApp group where you are part of the serious NEET PG preparing aspirants, where you have every minute Spardhaya Vardhate Vidya. So Clostridium difficile associated diarrhea. So where do you see that? It's most commonly associated with aminopenicillins is what you have to basically remember. Yes. So what are the different types of penicillin, doctor? We have to be very sure on this concept. Penicillins may penicillin G, हरीश जी, मुरली जी, अलेख जी, वैसा पेंसिलिन जी भी है. सो ये जी क्या है? बेंजाइल पेंसिलिन होता है, पेंसिलिन जी इसको देता है पेरेंटरली. You have crystalline penicillin, which is sodium penicillin. Procaine penicillin, most allergic. Benzathine penicillin is the longest duration penicillin. That is what you have to basically remember. Then penicillin V is called phenoxymethyl penicillin, which is typically available orally. Then you have aminopenicillin, ampicillin, amoxicillin, and these are the ones which are often associated with Clostridium difficile associated pseudomembranous colitis is what you need to remember. You have extended spectrum penicillins which are anti-pseudomonal. गर्मा-गर्म रिमेंबर करना है ये चीज़ों को. बहुत बार हम डिस्कशन किए और all these topics, videos, 953 video topics and the associated videos and PPTs, they're all available for you, doctor, in the onlinembbs.com video library. So you can always call our helpline to get a subscription for whatever the fee that you can pay, most affordable fee that you can pay. We'll be more than happy to have you online with us in the onlinembbs.com. Now, doc, carbenicillin, mezloxilin, piperacillin, ticarcillin, they're all called as the extended spectrum penicillins. What are the beta-lactamase penicillins, which are fundamentally anti-staphylococcal penicillins? So you should remember methicillin, cloxacillin, neficillin, oxacillin, they're all considered to be the beta-lactamase resistant penicillins is what you have to basically remember. Now, doctor, what are the drugs which are used in the postpartum hemorrhage? What are the drugs that we use? In fact, we'll be using all of them: misoprostol, dinoprostone, PGF2 alpha, and oxytocin. All of them are used in postpartum hemorrhage. Postpartum hemorrhage is one of the 953 high-yield topics. Those who could not get the 953 high-yield topic list, doctor, please call our helpline and they will be helping you to get the list. So first of all, always that list is important. Why it is important is, knowledge is unfathomable. 19 subjects, a big ocean. So you need to be very clear, what are the first things first? So these 953 topics, at most half an hour each topic you invest your time. 450 hours maximum is enough for you to prepare. So that is how we devised this top NEET PG in 120-day program. Now doctor, chlorpromazine is an antipsychotic that also acts as an anxiolytic and produces the sedation, dry mouth and hypotension. Now the examiner's question is, why these side effects happen? On which receptors is it acting? H1, M1, M2, which is cholinergic receptors, it is by the action on on the histamine and the cholinergic reaction. Anticholinergic will lead to dry mouth, basically. Alpha receptors will lead to hypotension. And H1 receptors action lead to sedation. That is what you have to emphatically remember. So, the chlorpromazine, if you take chlorpromazine, it acts on the dopamine receptor, alpha receptor, and M receptors and H1 receptors, muscarinic and H1 receptors. Out of all these, dopamine effects are a major thing to remember, and it produces a lot of CNS, autonomic and endocrine side effects is what you have to basically remember. Wherever we have about 100 online students, very happy to see. Please tell all your friends also to subscribe to this youtube.com/onlineMBBS. Press on the bell, and then you have, if I get time, even at midnight, I love to spend a couple of hours discussing about 100 questions with you before I go to sleep. Now, it is official. I'm an edict for all of you, right? So, your preparation, you are winning, you are topping the exam is no more your mission, it is my mission. So, doctor, if you look at the chlorpromazine, it acts on the D2, 3+, and on 5-HT, 2+, H2, 2+, histamine, H1 receptors, muscarinic, 3+, alpha-1 is 3+. That is the chlorpromazine. So you know very well that the antipsychotics are being divided into typical agents and atypical agents. Atypical agents have a relatively lesser amount of extrapyramidal side effects. So, chlorpromazine, thioridazine, fluphenazine, haloperidol, they're all called first generation. Whereas clozapine, aripiprazole, quetiapine, olanzapine, risperidone, they're all called atypical agents is what you need to fundamentally remember. A bank employee felt depressed. No interest in activities came to the AIIMS OPD and he was started on escitalopram. What class of the drug escitalopram belong to, doctor? Can you please punch the answer? I am expecting a answer from all of you. Yes, Samsung, Harish Reddy, everybody. What is the class of drugs does escitalopram belong to? Excellent. Tapai And albatross, everybody is saying SSRIs. So you should know what are the class effects as a class SSRIs. What are the side effects which are caused by the SSRIs? You should be very sure. So they can lead to vivid dreams, anorgasmia. However passionate is the sexual activity, if the orgasm doesn't come, the end result nahi aa raha hai, right? So nausea, vomiting. So these are the important side effects is what you need to basically remember. So escitalopram, unlike the other SSRIs, it binds with both the sites of the serotonin receptor, primary and allosteric sites. Whereas the other SSRIs and SNRIs, they only bind with the primary site. That is the reason the escitalopram relatively is very strong in its effects, is what you have to basically remember. Now, large doses of acyclovir are recommended for treating the genital herpes in HIV. Genital herpes in HIV. And the severe frequent recurrences are seen in HIV patients. Both of them are true, but the reason is not the reason for the assertion. That is a point you need to basically remember. Lot of students have a confusion on simple thing, my bol raha hu. Herpes zoster. A good number of you may be knowing it, but still, fir bhi, I'm an obsessive compulsive teacher. I believe all should know all the things. That's a policy. Herpes zoster. Second is herpes simplex. Simplex is your HSV virus, doctor. Herpes zoster is what? Chicken pox. In the childhood, whatever the chicken pox that we get, once our immune system is altered, that lead to development of the recurrence, relapse of it. That is herpes zoster. Whereas herpes simplex is, you have two types, HSV1, HSV2. One is facial oral and two is genital. So that is the HSV. There is a difference between the two. मगर दोनों में हम एसाइक्लोविर का ही इस्तेमाल करते हैं. So thank you, Bhagya. So this is our 1 minute. Is this our? Can you please punch on this? I am unable to get. This is a WhatsApp link actually. The new WhatsApp group. No, I could not get the full WhatsApp link. उसको click करे तो आगे नहीं बढ़ रहे. Bhagyalakshmi, please post the proper WhatsApp link. This link is not going forward. Yeah. So, Akhila says, what is the reason for giving high doses? Acha, that is still a question unanswered, right? Fundamentally, it is the pharmacokinetics and pharmacodynamics of the drug that decide the dosage. It's not any specific reason, but for the pharmacokinetic reasons is what you need to remember. Do you know how painful it is to take acyclovir? 400 mg orally every 8 hours. Alarm clock laga ke 3 baar, almost for 14 days you have to take the oral acyclovir. Intravenously it is 5 mg per kg IV every 8 hours for 7 to 14 days. Then if it is episodic outbreak, then 200 mg orally every 4 hours. Every 4 hours, 6 times alarm clock laga ke lena padta. Right? 5 times a day, episodic scenarios ko. For 5 to 10 days, you have to take 200 mg orally every 4 hours. 6 times एक tablet को लेना, वो भी याद रख के लेना, is a challenging thing actually for the patients, right? Now, which is correct about digoxin? The earliest side effect of the digoxin is the nausea and vomiting. सही बात है. Hypokalemia leads to digoxin toxicity, but digoxin toxicity leads to hyperkalemia. ये थोड़ा क्लियरली समझ लेना डॉक्टर. हाइपोकेलीमिया के वजह से डिटॉक्सिसिटी आएगा, मगर डिगॉक्सिन क्या करेगा? सोडियम पोटेशियम एटीपेस पंप को इनहिबिट करेगा. सो दैट इज द रीजन दिस लीड्स टू हाइपरकेलीमिया. Gotcha? And hyperkalemia will lead to the development of the cardiac arrest. So, hypokalemia predisposed to digoxin toxicity. Digoxin toxicity leads to hyperkalemia. Hyperkalemia in turn leads to cardiac arrest. So, this is the sequence which you have to be 100% sure about. हम बहुत खुश हैं. 119 online students every day evening 7 p.m. to 11 p.m. all 365 days. Agar if we have energy, time, we will have a free live online broadcast doctor. हम एक 100 MCQs डिस्कशन करेंगे. कभी कभी टॉपिक वाइज ऑफ ए सब्जेक्ट खत्म करेंगे, कभी कभी फुल पेपर लाइक दिस एम्स पेपर we will try to do the review, right? So this session, this live broadcast is free, but after the session is over, we will remove the video and then put it on our online mbbs.com video library. You should apologize us for that, because we want you to pay subscription by that. So that is how we will be able to survive an organization, to sustain all our production team and etc. etc. But yeah, otherwise, the live online broadcast is a free thing. That's not a big deal. And we are, in fact, thankful to all of you, because since you all came, हम सब बैठ के पढ़ने के लिए एक मौका मिल रहा है. That is what any teacher love to have it, right? Yes. Now, doctor, let us talk about the digoxin and all its side effects. There are visual changes, visual disturbances in the color vision, blurring, photophobia, anorexia, nausea, vomiting, and very important cardiac side effects. Digoxin is parasympathomimetic, doctor. Vagomimetic होता है. Vagomimetic. Why do we use digoxin in case of any atrial fibrillation? क्यों इस्तेमाल करते हैं? Atrial fibrillation नीचे वेंट्रिकल में नहीं जाना, इसके लिए गेटकीपर कौन है? एवी नोड है. एवी नोड को सप्लाई करता है वेगस. इसलिए हम ए वेगस को जाके कहते हैं, भैया ऊपर के एट्रियल फिब्रिलेशन को नीचे वेंट्रिकल्स को जाने नहीं देना. So you need to use the digoxin for that purpose too, because of its parasympathomimetic effect. But that effect ज़्यादा हो गया तो क्या होता? It will lead to bradycardia, AV block, extrasystoles. It can also lead to paroxysmal atrial tachycardia. By itself, it can predispose sinoatrial arrest and ventricular tachycardia. Now, what are the miscellaneous side effects of the digoxin, doctor? Gynecomastia and skin rashes can occur with the digoxin, is what you have to basically remember. Now, the pH of the gastric acid is 1.2, pH of the intestine is 6, and pK of the weak acids like paracetamol is 9.5, phenobarbital is 7.2, and a weak base like diazepam is 3.3. अभी एग्जामिनर आपसे पूछ रहे हैं, what is the effect of pKa on the acidic and the basic drugs? So remember, doctor, paracetamol is present in non-ionizable form and hence easily absorbed from the stomach. Then phenobarbital is absorbed from the small intestine than the stomach because it has more blood supply, small intestine. Then diazepam is absorbed from the small intestine. So that is what you have to emphatically remember and understand. So acidic drugs जो होता है डॉक्टर, acidic drugs जो होता है, they are largely unionized in the stomach and absorbed faster, while the basic drugs are absorbed faster in intestines. This is the principle which you have to very clearly understand. Now, if you alkalinize the urine, acidic drugs are excreted faster, is what you need to remember. Whereas the basic drugs are excreted faster if you acidify the urine. So, urinary acidifiers are used for that purpose, is what you have to remember. With regard to the Plasmodium falciparum, beautiful question. So, there are, for a large period of time, there was no drug resistance against falciparum malaria. But now, even falciparum malaria also, drug resistance has been reported. Now, doctor, if you look at the other drugs, quinine, doxycycline, clindamycin, they're all effective in the treatment. Quinine, doxycycline and clindamycin. Artemether, lumefantrine, they're also effective. And artesunate, World Health Organization clearly told, भैया अकेले मत यूज करना क्योंकि इसके वजह से होता है resistance become widely spread, is what you have to basically remember. So now doc, what are all the WHO recommended regimes for a uncomplicated falciparum malaria? You can use artemether with lumefantrine, artemether with amidoquine, artesunate with mefloquine, which is very effective in India, and you can use the artesunate sulfadoxine pyrimethamine, but it is showing especially for the areas of high level resistance. Now if you look at the uncomplicated Plasmodium falciparum treatment, what is it? We use the artemisinin combination therapy, is considered to be the drug of choice for all confirmed cases of uncomplicated falciparum. And you can combine this artemisinin with primaquine on day 2, is what you have to remember. Now, if there is a Plasmodium vivax, Plasmodium vivax, how are you going to treat Plasmodium vivax? In case of Plasmodium vivax, it is the chloroquine which is considered to be the drug of choice. 10 mg per kg on day 1 and day 2 and 300 mg on day 3 is what you have to remember. Then primaquine is given at a dose of 0.25 mg per kg for about 14 days to be added in addition to the chloroquine in order to prevent the relapse. But primaquine contraindications, you have to be very sure. G6PD deficiency, infants, pregnant women, in all these people, primaquine is contraindicated, is what you have to ultimately remember. Now, in case of the Plasmodium falciparum, as what we have discussed, chloroartesunate is considered to be the drug of choice. How do you administer it in falciparum? 2.4 mg per kg intravenously on admission at 0 hour, then at 12 hours and 24 hours you have to give, and then once daily till the patient takes orally. That is considered to be the management of choice. Then if you don't get artesunate, alternative to the artesunate is quinine. That's the point you need to appreciate in falciparum. Now, suppose you have pregnancy, one of the favorite areas of the examiner. How do you want to treat Plasmodium falciparum in pregnancy? देखिए डॉक्टर साहब, मलेरिया is the most high yield topic in pharmacology में 50 topics है, 50 topics. There are about 1100 MCQs of the last 15 years of the All India NEET PG question bank and AIIMS question bank we have discussed and made it available in the online mbbs.com, right? So out of the 50 topics, anti-malarial drugs, garma garam topic, so many times same questions are repeated. So that's the reason, doctor, 953 topics पहला क्या है समझ लो, उसके बाद उसमें कितने टॉपिक्स आप ऑलरेडी अच्छा है, कितने टॉपिक्स इंप्रूवमेंट होना है जांच लो. Then catch up with the online mbbs.com video library and try to do the revision as early as possible, topic after the topic, and you will take about half an hour to 45 minutes on each topic to revise a discussion on 35 to 40 questions. Just like the discussion we are having now, we also debated all these topics and made it available in the online mbbs.com. Then you also have the PowerPoints also there, so no worries, and maintain your 200 pages notebook. That is the simplest secret to success. First trimester में parenteral quinine is considered the drug of choice, and second trimester and third trimester में you can give artemisinin derivatives in case of the pregnancy with the falciparum malaria is what you need to remember. Now, how do you give prophylaxis? Prophylaxis में two types of prophylaxis, doctor. Short term, long term prophylaxis. Short term is given less than 6 weeks, long term is given more than 6 weeks. Short term के लिए doxycycline 100 mg per day to be started 2 days before and continued for 4 weeks after leaving a malarious area. Examiner छोड़ेगा नहीं, precisely पूछेगा 2 दिन के पहले देते, 1 दिन के पहले देते, 1 घंटे के पहले देते. Exam hall में you should not have any confusion. Spinal cord level पे फटाफट you should wait. Hey, where is my anti-malarial question, man? Oh, here it is. What? You have to kill it. Where is my question on Wolff-Parkinson-White syndrome? Yeah, it is there. Kill it. Like that, 953 topics you should anticipate, go and hit the examiner. That is how you become the winner. You should not take more than 15 seconds to answer a question. 1 minute में 4 questions khatam and 300 questions should be over in 1.5 hours. You should walk out of the exam hall. That should be your perfection by the time you reach January. इसके लिए you have to do only one thing. Spend every evening with Dr. Murli Bhardwaj and enjoy this Chai Pe Charcha and also be part of our WhatsApp group. So that is the way you will win. Mefloquine 250 milligram weekly, that is 5 mg per kg of body weight per week to be started 2 weeks before going to the affected area and continued for about 4 weeks after leaving the affected area is what you have to remember. Now, doctor, a 53-year-old is found to be hypertensive stage 2 without any comorbidities. Then which drug do you want to start? Chlorothalidone, thiazide diuretic. This is the most important part of our discussion, doctor. JNC8, Joint Nation Committee, has given hypertension recommendations. What is the JNC8 recommendations? Look, how is the age? Age more than 60, age less than 60. If the age is more than 60, what is your goal? How much should be your systolic BP and diastolic BP? Systolic BP should be maintained less than 150. Earlier days, we used to treat the patients strictly 120 बोल के बोलते थे सारे patients को. अभी JNC8 आके बोला भैया 60 above है, already there are calcified blood vessels. इतना strict antihypertensive नको देना, patient will go into hypotension and quality of life चले जाएगा. So less than 150, diastolic BP less than 90. Whereas if the patient age is less than 60, systolic BP is 140, diastolic BP should be maintained less than 90. Then typically if he is a black patient, we are Indians are like American blacks only in our epidemiological characteristic features. So initiate thiazide type of diuretic like chlorothalidone or calcium channel blocker, alone or in combination. Alone or in combination. Now there is another important thing. Suppose if patient of all ages, but diabetes is present, but no chronic kidney disease. This is the second situation. What is the goal? All ages, diabetes is there, no CKD. Examiner is going to give all these combinations. JNCA treatment guidelines, examiner is very obsessive in asking. So the blood pressure goal यहाँ कितना हो जाता? Systolic BP less than 140, diastolic BP less than 90. Whatever the age, अगर diabetes है तो careful रहना. Systolic BP को less than 140 रखना. अगर diabetes नहीं है, age more than 60, समझो, वहाँ systolic BP can be up to 150. That is what you should remember. Then if the systolic, in order to keep the systolic BP less than 140, diastolic BP less than 90, all ages diabetes present hai to, you look whether they are black or white. We are black only, and you initiate thiazide diuretic or calcium channel blocker is what you have to remember. Now the next situation is all ages, CKD is present with or without diabetes. CKD, chronic kidney disease is present. यहाँ आपका BP जो होता है डॉक्टर less than 140, diastolic BP less than 90 मेंटेन करना है. ब्लैक हो या व्हाइट हो, doesn't matter, काला हो या गोरा हो. Initiate ACE inhibitors, ARBs, alone or in combination with other drug class if the CKD is present, is what you have to remember. Dr. Sethu Murugan rightly adds that ACE inhibitor should be initiated. Right, doctor? So, isko bhulna mat. Then, few important principles of practice. BP management, sugar management, migraine management. ये सब चीजें डॉक्टर, fundamental expectations from any doctor. Patient expects you from any doctor. As MBBS passed on, PG or no PG, we are supposed to be very clear about these protocols. Now, maximize the first medication before adding second. Try to have enough dating with your first girlfriend before you eye on her roommate. That is very important in hypertension management. Add second medication. Before reaching the maximum dose of the first. First का maximum dose reach होने के पहले ही second initiate करो. Right? Then start with two medications separately or in fixed dose combination. These are the important principles. अच्छा भैया, what are the diuretics which are called as thiazide or thiazide-like diuretics? Hydrochlorothiazide, chlorothiazide, chlorothalidone, indapamide, metalazone. These are all called as thiazide or thiazide-like diuretics. But what is the difference between a chlorothiazide versus metalazone? Typically, Thiazide diuretics, for it to act, it need to come into the luminal side of the membrane and it should act. Membrane के luminal side को reach होना है. So, if somebody is having a very low GFR, the hydrochlorothiazide cannot reach the luminal side. इसलिए we use the metolazone. Even with a low GFR, it can be able to act unlike the thiazide. So इसलिए अगर किसी का GFR low है तो preferable thiazide or thiazide-like diuretic is metolazone is what you have to remember. Now, what are the causes of acute liver failure? Most of the acute liver failures are all paracetamol, doctor. Be very sure about it. Children may, what are the causes for the acute liver failure? Acetaminophen toxicity followed by metabolic disorder, autoimmune, viral hepatitis and hepatic ischemia. Whereas in the case of the adults, acetaminophen, indeterminate causes. Acetaminophen is most common cause. Paracetamol बोल के हम ले लेते हैं. Fever है ना, और एक paracetamol ले लो. I don't want fever to rise at all. Please don't do that. There are a good number of patients who acute fulminant hepatic failure because a hyperaggressive acetaminophen use it to treat. Drug-induced liver injury. You have to be very sure. Third cause, hepatic ischemia, autoimmune, and lastly Wilson's. So the list of the causes of the acute liver failure, you have to be quite sure about, doctor. Now, an affected male does not have affected children, but an affected female always has an affected children. What type of inheritance? ये तो हम बहुत बार डिस्कस करके थक चुके. So, what is this, doctor? Mitochondrial. If mama is causing it, but not papa, that is mitochondrial, right? Now, acute inflammatory response, where do you see? In the case of the necrosis. So, what are the differences between apoptosis and necrosis? Recently, हमने discuss किया ना, doctor. Every day evening, last 1 week, full week, 450 MCQs in the divided into 40 topics of the All India MDS entrance exam का general pathology question bank हम discuss करके फेंक दिया, है ना? So उसमें हम apoptosis versus necrosis के differences क्या है discuss किया. Inflammation necrosis में होता है, apoptosis में नहीं होता है. That you have to emphatically remember. Acute inflammatory response, where do you see? Once more, in the case of the necrosis. Now, reversible cell injury. Cell injury के बारे में हम कितना discuss किए थे last week. Those who missed the class, no worries. You can give a call to our helpline. You have all these discussions which are happening over here. 9000-868-356 is our helpline number. All these discussions are available, doctor, in onlinembbs.com video library, right? So हम 20 साल से यही काम पे हैं. It is our passion, it is our religion to make the people win a top rank in the entrance exam. Whatever be your background, आपका भूतकाल को भूल जाओ और वर्तमान के बारे में सोचो. That's the only thing. You should live today and love tomorrow and forget yesterday. So a lot of students will have that kind of a different feeling. भैया मैं एनाटॉमी के डेज में रोजा को प्यार किया, बाद में पूजा को प्यार किया सेकेंड ईयर में, थर्ड ईयर में सुजा ने मुझे डंप किया, मैं कुछ भी नहीं पढ़ा, मैं तो पूरा 4.5 years यही काम पे बैठा हूँ. नो वरीज. नाउ यू कैन स्टार्ट another 4 months. हम मिलके भजन करेंगे और टॉपर बन जाएंगे, right? So that is the deal with all of you, doctor, right? So Ajit Sharma is asking, sir, what is your schedule to previous year MCQs? Means timing and fixed duration. Whenever I get time, doctor, evening 7 to 11 p.m., I love to spend with you. And already all this previous year, last 15 years question bank is available in the online mbbs.com video library. So you can give a call to our helpline and buy the subscription to the top NEET PG in 120-day program, right? So whenever we get time, we will keep picking up some question banks and every week, every 15-20 hours, we'll try to finish the high yielding topics in a particular subject, right? So please do call, and also you our helpline को पूछे तो 9008683356 आपको WhatsApp ग्रुप, our study group में आपको शामिल करेगा, and that is a very good place where you have real serious classmates. There are about 260 in every group. We are creating a large number of academic groups. कभी कभी अच्छा पोस्ट जो होता है एक ग्रुप में, वो ले जाके दूसरे ग्रुप में भी हम शेयर करेंगे, हैंड रिटन नोट्स एक्सेट्रा एक्सेट्रा. That way you are constantly buzzing with the learning activity, which is very important. So doctor, mitochondrial deposits जब दिखता है, that is the time it is irreversible, doctor, irreversible, please remember. Whereas blood formation, cell swelling, loss of microbial, they are all the things that you see in case of the reversible cell injury. That is what you have to basically remember. Now, for the detection of the intrinsic pathway of coagulation, what do you use, doctor? APTT. PT is for extrinsic pathway. So already all of you know very well, factor 7 ko kate extrinsic pathway. 2 become 2A, 2A, that is prothrombin, thrombin बनेगा, और मिस प्रोथ्रोम्बिन, मिसेस थ्रोम्बिन बनने के लिए आपका किसका जरूरत है? 5 and 10 का. और ये 10 को एक्टिवेट करने का जिम्मेदारी किसको है? 7 को है एक्सट्रिंसिक पाथवे में. ऑल द रिमेनिंग थिंग्स 12, 9, 8, all these things come under intrinsic pathway. And intrinsic pathway is by APTT, extrinsic pathway is by the PT, is what you have to emphatically remember. Now, which is not a homeostatic agent, I mean hemostatic agent, bleeding को stop करने वाला agents कुछ है. Zeolite, chitosan, kaolin, they're all called as hemostatic agents. Zeolites, they are microporous aluminosilicate materials commonly used in commercial adsorbents. Chitosan is produced by deacetylation of the chitin, इसलिए इसको chitosan कहेंगे. Chitosan is the one which is used if there is any trauma, severe bleeding is there as a hemostatic agent, is what you have to basically remember. Chitosan is what you should remember. So, आप सबके लिए एक chitosan bandage है. It is a biodegradable, non-toxic carbohydrate derived from chitin, and chitin is a naturally occurring substance of the zeolites which is being used. Now, doctor, dystrophic calcification, where do we see? This is giving me a deja vu feeling. Last week, All India MDS entrance exam का general pathology last 15 years का question papers से 450 topics, 450 questions को हम 40 topics divide करके पढ़ाई किए, है ना? उसमें calcification के बारे में गर्मा गर्म discussion किए थे. Same ditto is in the AIIMS. MD students के लिए भी यही क्वेश्चन है. सो इसलिए एग्जामिनर एक ही है, परमात्मा एक ही है ना. FMG हो, नीट पीजी हो, नेक्स्ट एग्जाम हो, कुछ भी वही परमात्मा कंडक्ट करना पड़ता है, नैट बोर्ड। इसलिए नैट बोर्ड इज वेरी स्पेसिफिक, व्हाट टू आस्क, how to ask, what question bank, what are the expectations they have to filter the students before they give the rank. So doctor, dystrophic calcification जो होता है, that is typically seen in case of myositis ossificans. So metastatic calcification occur in hypercalcemic conditions. Dystrophic occur in the deranged or dead tissues is called dystrophic, is what you need to remember. If the DNA is damaged in the cell cycle, which gene leads to the cell cycle arrest? Once more, cyclins, CDK inhibitors, CDKs, इस सब के बारे में हम लास्ट वीक पैथोलॉजी 450 MCQs 40 टॉपिक्स डिस्कशन में किए, और we also made this last 15 years JIPMER, AIIMS, FMG, all these exams topic wise classified and discussed and put it in onlinembbs.com, top NEET PG in 120-day program. So Dr. P53 इसका स्टोरी क्या है? Once more, ये कितने बार डिस्कस करे तो भी अच्छा डिस्कस करेंगे बोल के फीलिंग आने वाला टॉपिक है। जब डीएनए डैमेज हो जाता है, there is a checkpoint at the G1 phase. G1 prepares the cell to enter into the synthetic phase. G1's checkpoint is there. So the damaged DNA will stimulate P53 to create a CDK inhibitor. CDK inhibitor typically will go and make CDK and G1S cyclin to get inactivated, and that will cause the cell to stop from multiplying beyond G1. That is what you have to basically remember. Now doctor, let's match these combinations. Howell-Jolly bodies, what are they? They are the nuclear material remnants. Then Dole bodies, they are the remnants of endoplasmic reticulum. Flame cells, where do you see? We see it in multiple myeloma. They are the immunoglobulin inclusions. Of course, or rods in case of the myeloid leukemia. They are the eosinophilic granules, is what you have to basically remember. So इसलिए doctor, Panchabhut, you have to be very sure. What are the Panchabhut for PG preparation? JIPMER, All India, AIIMS, PGI, FMGE, DNB also. You can add DNB also, excellent question bank. So DNB exam is no more there. 1, 2, 3, 4, 5, 6. 6 into last 15 years, you have about 5,000 MCQs in each. 6 into 5,000 is 30,000 MCQs hai. Don't read them without grouping them into topics, doctor. Very, very important point I want to tell you. You have to group them. All questions belonging to the same topic are brought to one place. That is what we have a artificial intelligence algorithm by our developer team, which will be able to bring all questions belonging to one topic to same place and arrange them in the descending order and then make them available for the teachers to discuss them. So we have about 30,000 MCQs which actually fall into 953 topics in the 19 subjects. इसको हम मास्टर करना चाहिए. करे तो more than enough, doctor. You don't need to worry at all. Mother, every time we feel we will do it, but we keep procrastinating. इसलिए हमने जितना भी वीडियो लाइब्रेरीज हो, जितना भी मोबाइल ऐप्स हो, जितना भी बुक्स हो, फिर भी where should the beginning should occur? Beginning should occur here. The mind should do the things that the heart is willing for. That's very important. But the heart does things that the mind doesn't know. So that is the reason my whole purpose is every day to push you into quickly solving extempore around 100 MCQs, and we throw the 100 MCQs into discussion so that you are ignited at the end of the discussion, so that you can go back and read all the video library and the books that you are having. Right, Doc? So let's be very sure. This is how a dole body look like. So what is dole body, doctor? Dole body hota hai remnant of endoplasmic reticulum. So where do we see these dole bodies is an important question. So in case of infections, burns, myeloproliferative disorders, pregnancy also, you see the dole bodies, and they are composed of rough endoplasmic reticulum, and the glycogen granules is what you need to remember. Now, doctor, 40-year-old male complaining of hot flushes. Each time he baths, very important question, right? Richa is asking a very good question. Sir, tomorrow physiology में कौन से टॉपिक्स लेंगे आप बताएं तो हम प्रिपेयर होके आएंगे. रिचा जी, टॉप 40 टॉपिक्स, वेदर ऑल इंडिया एमडीएस ले लो और एम्स ले लो, पीजीआई ले लो, कुछ भी ले लो. Let us say if it is physiology, they remain the same things. So what you best to do is you can I'll quickly take you, doctor, to this place, www.onlinembbs.com. 2 minutes I'll take you for the benefit of doubt of Richard. So yeah, so you have onlinembbs.com. So onlinembbs.com जाते ही आपको ये सब courses मिलता. In that you go to the view all courses. In that view all courses, you are having top NEET PG in 120 days. Top NEET PG in 120 days. So once you click on this top NEET PG in 120 days, you will come to this place, right? So here you are having, doctor, anatomy. You are having the first day anatomy. What are all the topics in anatomy? Anatomy daily test. Then day 2 anatomy में inguinal canal, ligaments, root value, lung, like that. So if you keep going down, all 120 days में 953 topics are being created for you. Every day we have provided one daily test, and even a daily test also has a video discussion. So अगर आप physiology को आ गया समझो, right? You have reached physiology. So physiology में blood pressure, most common topic, muscle contraction, nephron physiology, action potential, GIT physiology. So you have the AIIMS, PGI, JIP and all these question banks का खास questions को लेके हम discussion already किए थे, कर चुके. So you have all this available over here. So अगर ये आप revision करके next 5 days में मैं revision खत्म करूँगा बोल के लगाए तो parallelly we will also be doing a live online of the some more questions of All India MDS question bank. Even that's a very good question bank in this live session. So that is the whole idea, Richa ji. So but फिर भी आप 9008683566 से कॉल कीजिए और वो आपको हमारे स्टडी ग्रुप के व्हाट्सएप ग्रुप में शामिल करेगा और आपको टॉपिक लिस्ट वहाँ मिल जाएगा। आज का क्लास क्या हो रहा है सुबह दिलाएंगे आपको, so that you can start preparing for that and come to the class. So that is how you can supplement the video library with our daily online live sessions, right doc? Now, hot flushes क्यों होता है polycythemia rubra vera में? Basically, doctor, it is the myeloblast, which is considered to be the precursor for myeloblast, is the precursor for three things. You have lymphoblast and you have the myeloblast, lymphoblast and myeloblast. Myeloblast typically is a common origin for platelets, polymorphonuclear leukocytes and also for the RBCs. So stem cell level में polycythemia rubra vera में it is a myeloproliferative condition. It is not only RBC erythroid precursors that overproduce the RBCs, even the polymorphonuclear leukocytes also will start overproducing. That overproduction makes the mast cells, which are associated with the basophils. The basophils are one of the PMNs, polymorphonuclear leukocytes, which are typically elevated. So these basophils release the histamine. So when the person takes a bath, then this excess basophils suddenly release a lot of histamine and he starts getting pruritus. So that is called aquagenic pruritus. What is that called? Aquagenic pruritus is a classical feature of polycythemia rubra vera, is what you need to basically remember. So what is it associated with it, doctor? JAK2 mutation. JAK2 mutation it is associated with. Now doctor, what are the criteria, WHO criteria for the polycythemia rubra vera? Evidence of erythrocytosis, JAK2 mutations, they are the major criteria. Please don't forget, doctor. This is a favorite question of the examiner. Then if you do the minor criteria, hypercellularity with all the trilineage proliferation, all the three cell lines, PMNs, platelets, RBCs, all of them proliferate. And decrease the serum erythropoietin. This is very important. Polycythemia can be primary polycythemia, which is your polycythemia rubra vera, and it can be secondary polycythemia. कैसे differentiate करेगा आप? What is the way that you basically differentiate primary from that of the secondary polycythemia? Secondary polycythemia में erythropoietin levels elevate होता है, मगर primary polycythemia is not because erythropoietin came and told it. Erythropoietin आके उनको बताए तो erythropoiesis नहीं कर रहे हैं. प्राइमरी पॉलीसाइथीमिया ये माइलोप्रोलिफरेटिव है, एरिथ्रॉइड प्रिकर्सर्स प्रोलिफरेट हो गया है, इसके वजह से पॉलीसाइथीमिया है, इसलिए इसमें एरिथ्रोपोइटिन लेवल्स आर लो. दैट इज द फंडामेंटल डिफरेंशिएटर बिटवीन प्राइमरी पॉलीसाइथीमिया, व्हिच इज आल्सो कॉल्ड पॉलीसाइथीमिया रूब्रा वीरा, इज व्हाट यू नीड टू बेसिकली रिमेंबर. देन डॉक्टर, there is a endogenous erythroid colony formation in vitro. So these are the important criteria of the polycythemia rubra vera, is what you should remember. Now doctor, practical diagnostic algorithm, how do you approach if you are suspecting clinically in a patient that there is polycythemia rubra vera? Typically you have to get the JAK mutation and erythropoietin screening. JAK is positive, no doubt you can jump that it is polycythemia rubra vera. अगर JAK negative है समझो, if the JAK is negative, what are you gonna do? What are you gonna do? So if the JAK is negative, you look how is the erythropoietin. If there is a high erythropoietin, it is not rubra vera. वो तो सेकेंडरी पॉलीसाइथेमिया हो गया. अगर वो लो एरिथ्रोपोइटिन है समझो, then you have to do the JAK2 exon 12 mutation. Exon 12 mutation. First what you do, JAK2 V617F you look for. So you need to screen for it, and then you need to do the bone marrow biopsy. And bone marrow biopsy is the ultimate gold standard which help you to make out that especially JAK V617F negative cases of polycythemia rubra vera को भी पकड़ सकता है. इसलिए पैथोलॉजिस्ट को बोलते हैं सुप्रीम कोर्ट जजेस. हम जैसे फिजिशियंस रहते हैं ना, हम तो झूठ नंबर 1 झूठ मार खाली कहानी सुनाते हैं लोगों को. Always you know how the people are being humored. सच्चाई बताने वाले कौन है मालूम? The one who knows the truth, पैथोलॉजिस्ट. माइक्रोस्कोप में देख के वो जो बोलेगा वही होगा. A little more reliable guys are surgeons, क्योंकि वो काटेगा और डायरेक्टली देखेगा. Then starts the list of liars. We are all liars. I am also MD general medicine guy. हम तो कहानी बोलता, ये हो सकता, वो हो सकता, ये lymph node TB हो सकता, maybe it is even a lymphoma, वो सब बोलते हैं. हमसे भी ज्यादा झूठ बोलने वाले होता है रेडियोलॉजिस्ट. वो तो खाली शैडोज को देखता है, पेशेंट को टच भी नहीं करेगा. शैडोज को देख के maybe this shadow can be a cavity due to the vaginal granule metastasis. It may be a TB cavity. It may be a squamous cell carcinoma cavity. That is the list of order, right? What do you want to become now? Even if you get MD pathology, if you really have passion, you are becoming a Supreme Court judge. Please remember that, right? A lot of students call me after the results counseling. ये लेना या नहीं लेना, ये लेना या नहीं लेना. What do you say sir? जरा बताओ ना. बोलते कुछ भी ले लो, जिंदगी तो एक ही होता है, right? Now, whatever the seat you take, life is ultimately the same. Now, a thalassemia with a need for recurrent transfusion, but he develops transfusion reaction with fever and chills. What can be done to the blood to decrease these transfusion reactions? Always, doctor, you need to do leukocyte depletion. Leukocyte depletion. So that is the reason blood transfusions itna frequently avoid करना है as much as possible. Number 1, you are avoiding infection. Number 2, you are avoiding allosensitization. आपका ये भी वो ब्लड ग्रुप जो होता है ना डॉक्टर ब्लड में, ये भी वो ब्लड ग्रुप. ABO blood group is something that you are grossly identifying for a incompatibility. There are many minor antigens in the blood of Ramu which differs from Somu. ABO blood group may enable to take a decision to put the Somu's blood in Ramu, but that lead to allosensitization to a lot of minor antigens. Agar future में, in the future, if he has to undergo any transplantation or any blood transfusion, that predisposes to the development of a lot of allergic reactions. So, to avoid that, you need to give leukocyte depleted transfusions are the ones which are considered to be the preference. Now, what are the indications for the transfusion of a leukocyte reduced RBC? Favorite question of the examiner. Febrile non-hemolytic transfusion reactions. That is an indication for leukocyte depleted RBC transfusion करने के लिए. Similarly, if there is any HLA alloimmunization indication, then TRALI क्या होता है? Transfusion related acute lung injury. Then transfusion associated graft versus host disease. Transfusion mediated immune suppression. So these are all the specific scenarios where leukocyte reduced RBCs are being administered is what you have to remember. Arrange the clotting factors in the sequence. So, easiest question to answer, no big deal at all. If you know this, this important order, you should know, doctor, right? Now, factor 7 को कहते tissue factor. This decides PT. Factor 12, factor 11, factor 9, factor 8. Intrinsic pathway कहते और ये डिसाइड करेगा APTT. ये दोनों आके 2 को 2A बनाएगा and their main purpose, whether extrinsic or intrinsic pathway, is to activate factor 10. So this activated factor 10 and 5 मिलके प्रोथ्रोम्बिन को थ्रोम्बिन बनाएगा, थ्रोम्बिन जाके फिब्रिनोजन को फिब्रिन क्लॉट बनाएगा और फिब्रिन क्लॉट को फैक्टर 13 स्टेबलाइज करेगा. अगर फैक्टर 13 डेफिशिएंट हो गया तो PT is it affected? No. APTT? No. So PT normal, APTT normal, but patient is clinically bleeding, right? What is that situation, doctor? That is factor 13 deficiency. और एक factor 12 एक अजीब factor है. Even if factor 12 is deficient, 9, 11, 8 आके 10 को एक्टिवेट कर सकते. इसलिए patient will not have bleeding, no clinical bleeding. मगर factor 12 नहीं है तो decrease है तो APTT become prolonged. So what is the situation where APTT prolonged, no clinical bleeding? Factor 12 deficiency. What is the condition where PT and APTT is normal but clinically patient is bleeding? That is factor 13 is what you have to ultimately remember. Now, with regard to amyloidosis, what is the true statement? Once more, I am getting a deja vu feeling. All these things we have discussed in great detail in the last week pathology. So, doctor, secondary amyloidosis is commonly due to Mediterranean fever. And on Congo red staining, there is an apple green birefringence. AL is the kappa light chain, which is typically elevated in the case of the multiple myeloma. And senile amyloidosis is not due to beta 2. What is senile amyloidosis is due to? So this is the table which you have to become champion. Primary amyloidosis, it is the immunoglobulin light chains AL which is seen in the case of the multiple myeloma, and plasma cell dyscrasias is what you should remember. Secondary amyloidosis जो होता है इसको reactive systemic amyloidosis कहते हैं, and it is the AA type. SAA is the precursor protein and chronic inflammation is responsible, right? Chronic inflammation. Hemodialysis associated amyloidosis may. Beta 2 microglobulin is the protein, A beta 2M, and chronic renal failure is an associated condition. Now, what is called as the localized amyloidosis? Senile febrile cerebral amyloidosis, APP, it is due to the A beta and Alzheimer's disease. Similarly, endocrine causes. It leads to thyroid and islet cells of Langerhans may. Calcitonin is the precursor protein. ACAL is the fibril protein in medullary casting of thyroid. If the thyroid is leading to development of localized amyloidosis. Then AIAPP, islet amyloid peptide in type 2 diabetes is the one which is responsible. Similarly, familial Mediterranean fever may Yes, AA will be there, and just like secondary amyloidosis, and AA is a type of febrile protein. Then familial amyloidotic neuropathy में transthyretin will be there, ATTR, and अभी आ गया एग्जामिनर का क्वेश्चन, एम्स एग्जामिनर का, senile amyloidosis में क्या रहता है? Transthyretin and ATTR is what you have to remember. Now, doctor, about endothelial contraction. What are the different types of endothelial contraction that you know in inflammation? So you should remember that sunburn less than 24 hours is like delayed prolonged. Thorn prick leading to mast cell release is immediate and transient. And a bacterial infection with necrosis is immediate but sustained. That is what you need to remember about endothelial contraction. So if you look at the various vascular changes in inflammation, you have immediate transient response lasting 15 to 30 minutes because of the vasodilatation in arterioles, endothelial cell junction contraction because of the nitrous oxide and histamine, bradykinin and cytokines. Then you have a delayed sustained vascular response, and it is the vascular endothelial junction disruption. It is seen in the case of the sunburn, and cytokines and neutrophil induced reaction leading to the endothelial damage is the one which is responsible. Now, doctor, a CKD patient has to undergo dialysis. His hemoglobin was 5.2. So 2 blood transfusions were to be given. The first bag was completed in 2 hours. Second was started in midway between he developed shortness of breath. The vitals show increased BP, not hypotension, and pulse rate is 110 per minute. What is the underlying cause is a very important question. यहाँ this is a super duper question है. टैको क्या होता है डॉक्टर? ट्रांसफ्यूजन रिलेटेड सर्कुलेटरी ओवरलोड को कहते टैको. ट्रॉली and FNHTR, febrile reactions of transfusion, and TRALI, transfusion related acute lung injury is TRALI. How do you differentiate TACO from TRALI is the favorite question of the examiner. Good to see 100 students strong without leaving. That is the inspiration for any teacher. So doctor, it is an example of TACO. हम 5 पॉइंट्स डिस्कस करेंगे डॉक्टर टैको के बारे में, गर्मा गर्म पॉइंट्स. टैको, which is transfusion associated circulatory overload, is a overload that occur after transfusion of the blood. इसमें पेशेंट्स को acute respiratory distress होगा, increased BP, that is an important clue for you doctor. कहाँ है BP? 180/120 है इस पेशेंट में. Then there will be pulmonary edema because of the congestive heart failure, positive fluid balance, and ये सारे चीजें कब होता? Within 6 hours. That defines the TACO. Elderly people, infants, they are at the increased risk of the TACO. That's the point you need to understand. Now comes TRALI और TACO difference क्या है? Once transfusion associated lung injury हो गया तो BP low normal रहता, low or normal, but TACO में high BP रहता. वो है फर्क, right? Then body temperature is normal or elevated in TRALI, क्योंकि TRALI can occur, transfusion related acute lung injury can also lead to an elevated temperature, but TACO में body temperature is normal. Then how is the chest X-ray? Chest X-ray में TACO is what? Congestive cardiac failure, right? So heart had a overload, circulatory overload, इसलिए poor vascular congestion, pleural effusion, all the radiological features of a failed heart is what you find. Whereas in the case of the trally, there is no vascular congestion. Then the brain natriuretic peptide is typically low in case of the trally, but it is high because it is a congested heart failure. A failed heart means there is a एक बार हार्ट फेल हो गया, क्या होता? किडनी को ब्लड सप्लाई कम होगा. किडनी को ब्लड सप्लाई कम हो गया तो क्या होता? Kidney will not be able to excrete the water out of the body, and that lead to development of a volume overload, and this volume overload will stretch the chambers of the heart, and also they will go to the brain, and brain produces BNP. So elevated BNP का मतलब heart congestive cardiac failure में है, वो होता है transfusion associated cardiac failure में. Taco में, trally में नहीं, is what you need to remember. Then another important thing, pulmonary capillary wedge pressure. Where is it? Where do you see for it? Typically, pulmonary capillaries become pulmonary veins and drain into the left atrium. So pulmonary capillary wedge pressure is an indicator of the left atrial pressure. So if there is a heart failure, as in case of the taco, then this left ventricle pressure become elevated, left atrial pressure also get elevated, and you get a elevated PCWP. So elevated PCWP is a feature of taco, but not trally, is what you need to remember. Then how is the ejection fraction, doctor? Ejection fraction is abnormal in taco because it's a congestive cardiac failure, whereas trally mate is normal. If you go diuretics, any heart failure will improve. And the edema fluid typically in trally is a transudate, but in taco it can be exudate. That's the point you need to basically remember. So you remember now all these important differences, doctor. Now let's talk about the pathogenesis of trally. Generally, these subject-wise papers are supposed to be little faster because what we are trying to achieve is a quick review, fatafat review. Satish Lanka says, excellent explanation, sir. वाह हुजूर, इस कवाली को आप आए और हमारे कविता सुने और वाह वाह भी बोले, हम बहुत खुश हैं, right? So every day evening we'll spend a good time to read every day, doctor. That is a mantra of winning, let me tell you. At least mood है तो 5-6 hours, mood नहीं है तो कम से कम 1-2 घंटे. That is the need of the hour until the next 5 months. Train चलते रहना, रुकना नहीं, right? हाँ. So trally में होता है doctor systemic inflammation, lot of pro-inflammatory mediators. PMNs get sequestered, and once you give transfusion, these PMNs become activated. They release the microbicidal products, and that lead to endothelial injury, and you get an acute lung injury where the capillaries of the lung typically become leaky, is what you have to basically remember. So the first hit, there is an inflammation, IL-6 release, C-reactive protein, and in the second hit, there are anti-HLA class 1 antibodies in the blood that you have given. दोनों मिलके IL-8 को बड़प्पन करेगा, and that lead to pulmonary polymorphonuclear leukocytes to increase, and that lead to the transfusion related injury, is what I want to underscore to all of you. So what are the criteria to call trally? Number 1, acute onset within 6 hours. Clinical evidence of hypoxemia. Bilateral infiltrates on the chest radiograph. पल्मोनरी एडिमा होता है दोनों में, ट्रैली में होता है, टैको में होता है, टैको में होता है। पल्मोनरी एडिमा जो है दोनों में होता है, बट पल्मोनरी वीनस कंजेशन होता है ना डॉक्टर, पल्मोनरी वीनस कंजेशन, that is seen only in taco but not in trally. That is the point you should catch. And there is no evidence of left atrial hypertension or circulatory overload or elevated PCWP in case of the trally, and no other attributable causes is what you have to basically remember. Now doctor, this one classical story, हम इतना पढ़ रहे हैं इसके बारे में. This is a case of thalassemia major, and there is a bilateral pulmonary edema, and there is no cardiac megaly. Please remember, कार्डियोमेगली नहीं रहता, कार्डियोमेगली है तो सर्कुलेटरी ओवरलोड और वो टैको बन जाएगा. नॉर्मल कार्डियक शैडो हॉरिजॉन्टल डायमीटर मतलब वो ट्रैली होता है. दैट इज अ पॉइंट यू नीड टू अप्रिशिएट. सेम थिंग ARDS, acute respiratory distress syndrome, also like trally is pulmonary capillary leakage, but a normal PCWP, non-cardiogenic pulmonary edema होता है ARDS, is what you have to basically remember, right? Albatross is saying, sir, you said taco within 6 hours, but in slide trally showing 6 hours, right? Trally also is 6 hours, दोनों 6 hours के अंदर ही होता है, right? Now by day 5 everything cleared, so you are going to become those postgraduates in general medicine. ट्राली का पेशेंट को ट्राली से घर भी जाएगा with a normal chest radiograph by day 5. Right? Then in one of the intensive care units while doing a night duty, you will tell, अरे उस दिन उस रात हम सब चाय पे चर्चा पे डॉक्टर मुरली भरद्वाज के साथ ट्रैली वर्सेस टैको के बारे में गर्मा गर्म चर्चा किए, बोल के आप मुझे याद करना पड़ेगा. So this is a normal heart before transfusion, and after transfusion, doctor, you see there is pulmonary edema, but still the heart size is not enlarged. That is important to be seen. इतना storm है हिमालयास लद्दाख लेह के जैसे, फिर भी हार्ट का शैडो अगर आप देखें तो बड़ा नहीं, इसलिए ये ट्राली है, टैको नहीं है, is what you need to remember. So transfusion associated circulatory overload is typically associated with transfusion. Increased left atrial pressure will be there. And how do you treat the taco, doctor? You give oxygen, intubate if required, mechanical ventilation, diuresis, and you should always consider differential diagnosis. जब भी taco होता है, whether patient had a MI, that should not be missed. Even MI also lead to pulmonary edema, and a feature similar to taco. Trally जो होता है, this is due to the leakage of the fluid because of the increased alveolar capillary permeability. इसमें typically patient will have hypotension, not hypertension, and you need to give oxygen, intubate, mechanical ventilation, manage the hypotension with fluids, but also consider ARDS. That is the differential diagnosis for trally. And taco का differential diagnosis क्या है? MI, myocardial infarction is the differential diagnosis, is what you need to basically remember. So whenever we call trally, Canadian consensus definition क्या है? Any new acute onset of acute lung injury with hypoxemia, bilateral infiltrates, but no evidence of left atrial hypertension, and it should not be pre-existing but emerging within 6 hours at the end of transfusion and having no temporal relation to an alternative possibility for a acute lung injury is called as trally, is what you should remember. So doctor, that is the quick story. Once more, cardiogenic, non-cardiogenic pulmonary edema. Everything boils down to that. New ECG or ischemic changes are a new troponin T if it is elevated. What is the differential diagnosis for TACO? TACO always MI. Then if there is a clear temporal relationship to other risk factors for a possible acute lung injury like sepsis or aspiration, then that is a typical if there is no such association, that is tally. Agar hai to you should think of possibility of ARDS. Is what you have to remember. Now doctor, a 40-year-old male from Himachal Pradesh presented with this microscopic findings. What is the diagnosis? Chromoblastomycosis is what you have to remember. Verrucous lesions are an important clue. A HIV patient, chronic diarrhea presented to the OPD, and his stool examination is showing the oocysts which are acid-fast staining positive. So, which are positive for the Gill-Nielsen staining. So, Gill-Nielsen staining में क्या इस्तेमाल करते हैं? There is a strong carbamazepine 0.5%, carbamazepine 0.5% H2SO4 and Loeffler's methylene blue. This is the combination which is used in the Gill-Nielsen's reagent is what you have to remember. So in this doctor, what is the primary dye? Carbamazepine. Decolorizer is sulfuric acid alcohol or acid alcohol. Counterstain is methylene blue or malachite green is what you have to clearly remember. So this week we will discuss physiology. 500 questions khatam karenge, 700 questions topic wise from the last 15 years of All India MDS question bank. However, it is going to be very, very helpful because same basic sciences, there are about 8 medical subjects even for the All India MDS entrance exam, right? So question banks are all similar. Then after that, next week we will go for the microbiology. एक गर्मा गर्म चर्चा करेंगे. Microbiology का भी similarly another 600 questions are there in the MDS question bank, right? Now, gram stain. What is the primary stain? Crystal violet. Decolorizer is acetone, and counter stain is safranin is what you need to remember, and the spores are colorless, bacteria are violet. Modified Gill-Nielsen, carbamazepine, that's what examiner asked now. It can be 0.25 or 0.5% H2SO4. Counter stain is Loeffler's methylene blue, and the spores will be red and bacteria will be blue is what you should remember. Donner stain में decolorizer काली फर्क रहता, acid alcohol, and counter stain is nigrosin, and इसमें spores will be red and bacteria will be colorless. Then you have a Schaffer's Fulton stain, Abbott's method, Muller stain. I leave this PPT slide to you for you to have a quick review. Microbiology जरा बट्टी मारने वाला सब्जेक्ट होता है डॉक्टर, इसके लिए आप prepared रहना, mentally prepared रहना. मगर first round only you will have थोड़ा अजीब अजीब दिखता है, dry दिखता है, पढ़ रहे मगर भूल जा रहे, पढ़ रहे फिर भी भूल जा रहे. But second round you will be good, feel good, and WhatsApp group में keep punching questions, see how your classmates are answering, and some of your WhatsApp group classmates will be giving you currently we have 3 online mbbs.com WhatsApp groups. Almost all 700 students are there. So keep please give a call to our helpline 900868 and request for including you into the WhatsApp group 900868 Now arrange in the order of the gram staining. gram staining जब करते हैं microbiology second year MBBS means we are hot romantic mode. पढ़ाई कौन करेगा? वो माइक्रो का काउंट जाएगा और माइक्रोस्कोप में क्या दिखाएगा? यहाँ तो मेरे दिल के हसीना के आंखों में देखना है, देखने का टाइम है बोल के उस दिनों में हम सही तरह पढ़ते नहीं। तो एग्जाम में सिंपल सिंपल क्वेश्चंस पूछते। सो डॉक्टर, you should remember this very important point. You apply crystal violet, which is the purple dye. Then you apply a moderant, which is iodine. Barabar? Now, Sudhanshu is asking, any WhatsApp group, sir? Yes, we have a WhatsApp group, sir. But today I didn't get that invitation link. So this is our helpline phone number. So Sudhanshu, please call our helpline 90086836 and request for a inclusion of your number, and they will include you into the WhatsApp group. We have a garma garam WhatsApp group, high adrenaline, high testosterone, high estrogen ka WhatsApp group, which every day we study, we debate, we discuss. Questions will be flowing like river Ganges, right? Across the day. Then you give an alcohol wash, decolorization. Then you apply the saffronin, which is the counter stain. So agar gram positive hai to this is the color, gram negative hai to this is the color. This is the color is what you have to remember. So that purple color of that crystal violet will be typically retained by the gram positive, and the counter stains color will be picked up by the that is the saffron color is picked up by the gram negative, is what you need to remember. So जब crystal violet लगाते हैं आप, everyone is purple. Iodine is only a moderate. Then alcohol डालने के बाद gram positive continue to be purple and gram negative become colorless, and the counter stain saffronin का red color को gram negative पिकअप करेगा और वो red दिखाएगा, मगर gram positive continue to be purple. That is the point you need to remember. That's what examiner asked. So these are the gram negative bacteria, whereas these are gram positive bacteria. जो रेड कलर में दिख रहे आपको ग्राम नेगेटिव होगा, पर्पल कलर में दिख रहे वो होता है ग्राम पॉजिटिव, इज व्हाट यू हैव टू बेसिकली रिमेंबर. नाउ डॉक्टर, with regard to the biomedical waste management, this is another. Baba black sheep, have you any wool? Yes sir, 3 bags full. One is yellow, other is red, another is blue. Like a LKG, UKG student, nursery student, हम पढ़ना पड़ेगा इस टॉपिक को, right? So tell me doctor, yellow में क्या डालते, red में क्या डालते, blue में क्या, white में क्या? Be very sure about it. So you should remember, yellow में जाएगा chemical waste, red में syringes, ब्लू में जाएगा ग्लासवेयर, एंड व्हाइट ट्रांसपेरेंट में जाएगा स्कैल्पल ब्लेड, राइट? सो दिस इज द इंपॉर्टेंट लिस्ट you need to remember, doctor. You have no other option, right? So non-infected waste, cytotoxic drugs and chemical waste, they go into the black, which will go for the chemical treatment and secured landfilling. Then solid waste like infected dressings, POP gas, they go into the red plastic container and autoclaved and deep burial karega. Anatomical waste like placenta, pathological waste and body parts, they go into the yellow and deep burial karna padta. Then syringes, gloves and plastic waste, which are infected plastics, they go into the blue plastic bag, and you need to disinfect with chlorine solution, mutilate them and then send it to recycler. और sharps जो होता है, sharp items like needles and cut glasses, They go into the white plastic container. You need to disinfect with chloroquine, chlorine, and you need to put them into the sharp pit is what you have to basically remember. So summarize once more. Yellow. What will go, doctor? Into yellow, yellow, yellow. Hello. Where are you, mere yellow? So yellow में जाता है infectious waste, bandages, cotton, anything in contact with the body fluids, human body parts, human anatomical waste, solid biomedical waste. Yellow. Red. Fluid blood, chest drainage units, catheters, suction, and IV tubings, microbiology, biotechnology waste. Then blue and white, all types of the glass bottles, broken glass articles, even your broken heart if you don't read this, and outdated and discarded medicines and solid plastics. Finally, black के अंदर जाएगा, needles without syringes, blades, sharps and all metal articles is what you have to, and incineration waste, they all go into black. So this is important, doctor. इसके लिए इंटेलिजेंस का जरूरत नहीं है, परसिवरेंस का जरूरत है. आप याद रखना पड़ेगा. मल्टीपल टाइम्स दोस्तों के साथ जब भी मूड आता है बैठना, डिस्कस करना, right? And 48-year-old man hospitalized for 17 days on IV antibiotics, developed neutropenia, history of dysuria. Which antibiotic has a high chance of developing pseudomembranous colitis? It is the aminopenicillins. So you should remember, doc, ampicillin, amoxicillin, cephalosporins, clindamycin and other penicillins, they have a high risk. Most frequent, leading to Clostridium difficile infection is what you have to remember. Then quick facts about the pseudomembranous colitis, doctor. Penicillins, clindamycin, you will remember, highest risk, but most common treatment that you give to treat this condition is vancomycin and metronidazole is the treatment for the pseudomembranous colitis is what you need to remember. Which is a subcutaneous fungal agent out of all this. Sporothics Schenkii is the subcutaneous fungal agent. It is a chronic infection involving cutaneous, subcutaneous and lymphatic tissue, commonly seen in gardeners, is what you have to basically remember. So that is the end of our first part of the game. We have labored for a couple of hours, 2 hours. Now you should tell me, if you have energy, I will give you the next quiz, you solve it and I continue discussion. Up to you. What do you say? Chirag Goyal, Sara, Ajad, Albatross, petrol khatam या petrol है? Petrol है तो हम the next set of questions खत्म करेंगे. Choice. Chirag says we will have it is take too long, said Mayank. Continue, sir, says Nisha. Harish Reddy is saying, sir, can I get the subscription fee for some days? Definitely, you can give a call to 900868-356 and request for a few days to use it. No problem, doctor. You are important. Sudhanshu, continue please. Okay. So we have a few mixed responses. कोई बात नहीं. Tomorrow we will try to start a little more early. 6 बजे शुरू करेंगे. 6 o'clock, are you all okay? Or 7 शुरू करेंगे? What is a better time? 7 to 11 or 6 to 10? What is a preferable time, doctor, for all of you? So 6 is better, says Richa. 6. Okay. So between 6 to 7 shuru karenge. So tomorrow we will have a discussion, and also physiology we will try to review. And good luck to all of you. Enjoy a great time. Be in high spirits. That is important, doctor. Most important in life is himmat nahi harna. That is what anybody will tell, right? We should not lose the hope. Hope is the best medicine that any physician can be able to give. Never we cure. Sometimes we palliate, but always we comfort. That is the rule tomorrow when you finish your MD to a patient. किसी को ब्रेस्ट कैंसर है, क्या कर सकते हैं आप? Can you cure always? No. But always you can comfort. You can give your shoulder for someone to cry. So that is the reason when you are going for an exam, you should be sure what examiner want, what I should focus, and how I am going to revise it, how I am going to remember. If it is a problem of forgetfulness for me, it is a problem for everybody else also. इसलिए let me be in that group of around 200-250 students in that who are also seriously preparing for entrance, and collectively let us crack this exam. That should be your spirit. So thank you very much, and we will all see tomorrow evening at 6 p.m. Thank you.